Good morning, sir.
Morning. Ankur, you are presenting?
Yes, sir.
Yeah, we can start.
Okay, sir. Good morning, sir. Sir, I am presenting the case capsule given to me. Sir, my slides visible,
Yes,
sir?
yes. Yes, we can see. Yeah.
Okay, sir. So my patient is 33-year-old male patient, banker by occupation from Kota, and he has come with chief complaints of pain abdomen for 2 months and jaundice for 1.5 months. Patient was apparently alright 2 months before, then he started developing right upper quadrant pain, which was dull aching, gradually increasing in intensity, and remained for few hours of a day, not requiring any analgesics. It was localized and not associated with any aggravating and relieving factors. Patient also started complaining of jaundice with tea-colored urine without any pruritus. He has no history of fever and no history of any prodromal symptoms and no history of hepatitis and melena and no history of nausea, vomiting, no history of awareness of any mass per abdomen and decreased appetite or weight loss, any PATs and no history any suggestive of tuberculosis. And he does not give history of previous similar episodes of pain, jaundice, fever or any hospitalization in the past, and no any comorbid conditions. Personal history, there is no history of any addictions and he is vegetarian, normal sleep and bowel bladder habits are normal, family history is not contributory. Sir, summarizing. Sir, so he is 33-year-old patient without any known comorbid conditions, presented with right upper quadrant pain for 2 months and jaundice for 1.5 months without history suggestive of choledocal.
Yeah, I think we've discussed the history interpretation of jaundice several times, so I would not repeat it again, but quickly let us go through your slides. We'll just spend a few minutes on history. Go back. Okay, next. So, fine. Next, go to the negative history and just explain what you had in mind when you asked these.
So first, the fever associated with chills to rule out choledoitis, and prodromal symptoms to rule out hepatitis, and hepatitis melena to rule out portal hypertension, and this nausea vomiting, it can be associated with any hepatobiliary pathology, biliary colics to rule out that, and any awareness of the lump in the mass in the abdomen, just to rule out any mass is there or not. Gall means any mass, gallbladder or any liver mass he can feel or not, and to this decrease appetite and weight loss to rule out any malignancy or any malignancy. And so PATs to rule out, I had in my mind hydrated cyst to just
so in a patient with jaundice, hepatitis and melena, does it indicate only portal hypertension? Nothing else can explain hepatitis and melena?
No, sir. Means and other things can also explain, sir. This any malignancy, ampullary malignancy, periampullary malignancy, and
renal malignancy.
Yes.
So in a patient with jaundice, the tumors which can bleed would be duodenal tumors, papillary tumors, okay, ones which can ulcerate, and nausea and vomiting not only as a reflex of severe pain, but also if there is a malignancy in the head of the pancreas, malignancy in the gallbladder, which is causing gastric outlet obstruction. So
Yes.
that also can cause. And yes, Rajendra.
You have forgotten about hematobilia. as a cause for obstructive jaundice and hematemesis and melena. Hemophilia also can produce similar symptoms. So it's important to mention that because in certain parasitic diseases and also in a tumor that has spread like HCC, you can get tumor embolisms causing obstructive jaundice. At the same time, there will be melena associated with it.
Okay, sir.
Word lump and mass, although many textbooks use as synonyms, but I think it is better to call it a lump. Mass generally connotates a neoplastic lesion, whereas in a patient with jaundice, you can have a distended gallbladder, which is being palpated as a lump. So it's better to call it a lump. Now, in the history of tuberculosis, you have mentioned some symptoms, but what is the most important symptom which you haven't mentioned? What is one symptom which clinches the diagnosis of pulmonary tuberculosis?
Sir, cough.
Cough and ये तो public holdings में भी लिखा होता है. Hemoptysis.
Hemoptysis.
Hemoptysis. Okay, so
yes,
you can't talk of tuberculosis of the lung without mentioning hemoptysis. These are small things which you should make an attempt that you don't unnecessarily get caught and time is wasted on these small points. Next. Okay, next. Yeah, fine. Next. Okay, so what is your interpretation?
Sir, my interpretation, sir, I'm thinking benign surgical obstructive jaundice, and my differentials can be first, I'm thinking commonly cholelithiasis with choledocal lithiasis, and another, sir, I'm suspecting means Mrcp syndrome also. It can be, sir. And third, sir, I'm thinking choledocal cyst, and fourth, it can be hydrated cyst with cystobiliary communication, and very less likely very simple hepatic cyst which is compressing bile duct.
Let's discuss one by one. You said gallstones, CBD stones, but there is no history of cholangitis.
Sir, for means CBD stones are for every patient. There is no need. Means for all patients.
Your answer should be that yes, CBD stones may be associated with cholangitis, but it is not necessary that history is present in every case. In fact, you can have a CBD stone without jaundice also.
Yes.
But you don't make a diagnosis of CBD stone clinically if there is no jaundice. So you have to have jaundice to make a diagnosis of CBD stone. If cholangitis is there, it supports the diagnosis, but if it is not there, then it doesn't exclude it. So that is what your answer should be. Okay?
Yes, sir.
Second, you said Mrcp. Is Mrcp a clinical diagnosis?
No, sir. It is
not a clinical diagnosis. In a patient with Mrcp who turns out to be Mrcp, the clinical diagnosis will be biliary CBD stone disease.
Yes.
Okay. Mrcp is an imaging diagnosis.
Yes, sir.
So I don't think it would be right to make a clinical diagnosis of Mrcp because that is included in the diagnosis of gallstone and CBD stone.
Okay, sir.
So your second diagnosis, yes, right. Young patient with pain and jaundice after CBD stone, which is the commonest cause. I agree that it should be, or it could be choledocal cyst.
Yes, sir.
Third, you said hydrated. Now, hydrated, it is a possibility, but clinically you would not diagnose hydrated unless a lump is palpable.
Okay, sir.
Okay. So again, say for example, suppose this patient did not have jaundice, he just presented with right upper quadrant pain for 2 months. Would you make a diagnosis of hydrated? You would not.
No, sir.
Isn't it?
Yes.
So again and again I say that when you have to answer a question in theory paper, you have to list all possibilities, even the rare ones. But when you are discussing a case, you have to present or you have to discuss only the common, what is probable. What if you see 100 such cases, what you would see at least in 5 cases, not something which you would see in only 1 out of 100. Okay. And for the same reason, a simple cysts actually are very, very less likely to cause jaundice.
Yes.
I'm sure you must have seen very large simple cysts which are detected incidentally on ultrasound or CT, they didn't have any symptoms. So simple cysts are very, very unlikely to cause.
Yes, 1.5 months of jaundice.
Yeah. Okay, carry on. Everyone, please put off your mic. Some people's mic is still on.
Sir, general examination, patient is conscious,
Okay,
oriented.
before you proceed, let me ask you a question. So suppose I say this is malignant jaundice, you said benign.
Sir, first he is a young fellow, and he doesn't have progressive type of jaundice, and he doesn't have any loss of weight, appetite.
Yeah. So sometimes some examiners throw these googlies just to see how well prepared you are. So if you are confident, you should say it can still turn out to be malignant.
Yes, sir.
But nobody will make a clinical diagnosis of malignant surgical obstructive jaundice in this scenario.
Okay.
We all have seen young patients presenting with jaundice,
Yes.
malignancy, but we will not make a clinical diagnosis if this patient comes to OPD.
Okay, sir.
Yes.
So general examination, patient is conscious, oriented, comfortable, averagely built and nourished, BMI of 26, vitals are stable, ECOG performance status 0, and he actress, no pallor, cyanosis, pedal edema or generalized lymphadenopathy. Abdomen examination, inspection, abdomen is scaphoid. So abdomen inspection and palpations findings are within normal limits, sir. No any, and gallbladder is not palpable and no any palpable lump in the palpation.
Yeah, so the order should be reversed. Gallbladder, palpable or not palpable, is the most important clinical finding in the abdominal examination in a patient with jaundice. That should come first. Next should come whether any mass is palpable.
Okay.
Then comes hepatosplenomegaly.
Yes.
So the order in which you mention things is also tells me that how much weightage you are giving to each finding.
Okay. So percussion and auscultation and parectal examination also, sir, within normal.
So what will you do?
So,
Can this be hepatitis?
sir, yes, sir, it can be, but he doesn't have any history, means prodromal symptoms. So I did not keep that, sir.
What are the prodromal symptoms in hepatitis?
Sir, anorexia, malaise, weakness, and fever also it can be there, sir.
What else?
And some means sometimes this hepatitis or self-remitting also. So he has continuously for 2 months this history.
Usually, so aversion to smoking. Those who are smokers, they sometimes give this peculiar symptom that they don't feel like smoking. So that also has been reported. And yes, hepatitis going on for 1 month is unlikely. It is possible. Chronic, I think it's called. I don't know whether it will be called chronic active hepatitis. Check with one of your medical colleagues. But there are some cases where the jaundice can continue for a month or long. Okay, so what will you do? He comes to you in the OPD.
Sir, first I will do, sir, for diagnosis, sir, I will do first ultrasound abdomen to see the cause of the jaundice and pain, sir. And to see my I have kept my differential as polylithiasis with choledocal to see any bile duct and any stone is there in or not in gallbladder or any CBD is dilated or not, and to see cystic lesion is there, and to see liver also.
You have not mentioned clay colored stools. So does that limit your possibilities that you would consider?
Yes, sir. No, sir, means I have to mention, sir.
What conditions would cause jaundice but not be associated with clay colored stools? That was one of the reasons I asked you about hepatitis.
Sir, medical conditions, hemolytic anemias, and
Even in hepatitis,
pre-hepatic causes of hepatitis, jaundice can cause this jaundice without clay colored stools.
What about EHPVO with obstructive jaundice? In our country, it is pretty common.
Yes, so that can cause clay colored stool also, sir.
yes, clay colored stool is basically if there is a mechanical obstruction.
Yes.
In hepatitis, in most patients it will not be there, but in some patients where there is severe intrahepatic cholestasis, then they can even have pruritus, they can even have clay colored stool, but usually it is not there. So if the patient is passing high colored urine and clay colored stool, that point clinically we take it as a feature in favor of obstructive or mechanical obstruction.
Okay, sir.
Let's see the ultrasound findings.
So there is fusiform dilatation of extrahepatic biliary duct with query stones without intrahepatic biliary radicals dilatation and echogenic sludge in the gallbladder lumen with hepatosplenomegaly and grade 1 hepatosteatosis. And type 1A choledocal cyst with query cystolithiasis.
So this is one example where I say that do not try to find out the diagnosis of the case in the exam, because if you knew that this patient has choledocal cyst, even before the ultrasound, you will try, that is a human tendency, you will try to justify, and you might even say that my diagnosis is choledocal cyst, which will not be acceptable.
Yes.
So unless it is a child or an adolescent with a palpable lump and jaundice and cholangitis, where maybe you can make a diagnosis of choledocal cyst, but in an adult presenting with pain and jaundice, if you make a clinical diagnosis of choledocal cyst, that would not be acceptable. So if you knew the diagnosis, you would try to do that, or you would try to justify that. Okay, so how do you interpret this ultrasound report?
There is extrahepatic biliary dilatation of bile duct, and they have not mentioned about the liver, sir. Where means liver size, shape,
hepatosplenomegaly. It is mentioned hepatosplenomegaly with
okay,
grade
sir.
1 hepatosteatosis.
Okay.
That's all they can say on ultrasound.
Yes, sir.
Do you agree with their impression?
Why is there splenomegaly?
Sir, maybe because of this obstructive jaundice, this portal hypertension is developing.
So first, do you agree with their diagnosis that this is a choledocal cyst? On ultrasound, how do you diagnose choledocal cyst?
Sir, ultrasound, sir, this means if disproportionate dilatation of the bile duct is there compared to intrahepatic.
That is the key word, that the extrahepatic bile duct is dilated, but there is no proportionate dilatation of the intrahepatic duct. Now here they are saying that there is fusiform dilatation of extrahepatic bile duct, but there is no IHBRD. So that is what clinches the diagnosis of choledocal cyst. If they had said that there is dilatation of extrahepatic bile duct and IHBRD, then it could be mechanical obstruction due to stones, which is causing dilatation of the entire biliary tree. So disproportionate dilatation of the extrahepatic bile duct is the key finding which suggests that this is choledocal cyst.
Yes.
And because it is involving only extrahepatic bile duct, it is fusiform. They are right in labeling it as type 1A. Okay.
Yes, sir.
So, sometimes when you have stones in the gallbladder, stones in the CBD and a dilated CBD, it may be difficult to differentiate between obstructive mechanical dilatation of CBD versus choledocal cyst. So then you have to look at the image, either the ultrasound finding or the cholangiographic image, to see whether there is disproportion.
Okay.
That is one. Other is that you remove the CBD stones. If it is mechanical obstructive dilatation, once you remove the CBD stones, once you drain the CBD, the dilatation should come down and the CBD should become near normal. Whereas if it is choledocal cyst, even if you remove the stones, some dilatation would still persist. So that is what gives you the diagnosis. But yes, sometimes it becomes very difficult in clinical practice to differentiate between the two. Now coming back to Dr. Rajendra Desai's question, why there is splenomegaly? One reason you said that jaundice, which has caused portal hypertension. How does jaundice cause portal hypertension?
So biliary, after secondary biliary cirrhosis.
What is the duration of history in this patient?
Sir, but the history is very short, sir.
Very short.
Yes,
so
sir.
Nobody knows the exact time, but most people believe that at least 3 to 6 months of biliary obstruction, especially with recurrent cholangitis. So biliary
Yes.
obstruction with recurrent cholangitis is the precursor of secondary biliary cirrhosis, which then can cause portal hypertension.
Yes.
Is there any other method that obstructive jaundice pathology in the CBD can cause portal hypertension other than secondary biliary cirrhosis? Can in any other way portal vein get blocked?
So, this means splenic vein thrombosis.
Portal vein thrombosis. We are talking of biliary pathology. Splenic vein thrombosis, yes. If you are talking of pancreatic pathology,
yes, sir.
Then splenic vein thrombosis. But here we are talking of biliary pathology, bile duct pathology. So portal vein thrombosis. So you can have, for example, here of course there is no history of fever with chills to suggest cholangitis. But if you have an episode of cholangitis, you can have an inflammatory thrombus in the portal vein. Similarly, if there is a cholangiocarcinoma, if there is a gallbladder cancer, if there is a hepatocellular carcinoma, there could be portal vein thrombosis, which then can cause portal hypertension.
Yes.
Okay. Next, what will you do?
So I will do liver function test to see the jaundice and liver enzymes and hemoglobin, total count, PTINR.
Yeah, so PTINR is a part of liver function test as far as we are concerned. Labs may not put them in the LFT group, but as far as we are concerned, so you should mention PTINR or coagulation profile there rather than after the hemogram.
Okay.
Otherwise, the examiner will interrupt you. Are you not interested in looking at the PTINR? Okay.
Yes.
Let's see the profile.
So, hemoglobin, total count, platelets, all are within normal limit, and liver enzyme.
Rather than that, at this level, you could say that there is no evidence of even subclinical cholangitis. There is no evidence of hypersplenism. That is what you are looking for, especially because there is splenomegaly also. Then?
So bilirubin level is high, sir.
Sorry, I was wrong. Sorry, I looked at.
Sir, SGOT, SGPT are raised and ALP is, sir, actually, I was
ALP is normal, sir. Yes.
Yes, sir. Liver enzymes are slightly elevated, sir. Even ALP is elevated and bilirubin is very high, sir. In direct component is high, sir, 13.2, and albumin is normal. Electrolytes, create and INR is normal, sir. So subclinical cholangitis is there, sir, and along with obstructive jaundice.
There is obstructive jaundice, there is probably subclinical cholangitis, and liver synthetic functions are preserved.
Preserved, yes.
So, definitely you should not read the values. It is better that you give interpretation when the tests are shown to you, and you give interpretation keeping in mind what you were looking for. So here, first we were looking for any evidence of hypersplenism. We were looking for any evidence of cholangitis. and we were looking for the synthetic functions of the liver. More here, of course, the history is short, but if the history is long, then you are more worried about the synthetic functions of the liver.
Yes.
Okay. Next, what will you do?
Sir, I will do MRI abdomen with MRCP to see the dilatation and intrahepatic biliary ducts anatomy, and to see liver also, sir. Whether
there are stones in the CBD, why not go straight for ERCP?
Sir, it will more induce cholangitis. Already he is having subclinical cholangitis.
Okay. You can always put a stent. So the answer is that since ultrasound is strongly suggestive of a diagnosis of choledocal cyst, I want to further delineate the biliary anatomy, and there is no indication for therapeutic intervention. Today, ERCP and PTC should not be done for diagnostic purpose only. They should be done only when you are planning a therapeutic intervention.
Yes.
So here there is no indication. Subclinical cholangitis is not an indication for biliary drainage. Bilirubin level, unless you are planning a liver resection, is not an indication for biliary drainage, isn't it?
Yes.
So there is no indication for therapeutic intervention, and that is why I will not do a ERCP.
Okay.
Also, any other advantage of MRCP in this scenario over ERCP? What all you want to see on MRCP?
Sir, MRCP, sir, first biliary duct anatomy, sir, intrahepatic and extrahepatic, along with any anomalous junction with pancreatic duct.
Yeah, so you want to see both biliary and pancreatic duct.
Yes.
Means if you want to do ERCP, you will have to cannulate both.
Both, sir.
Which further causes problems in terms of both cholangitis and pancreatitis.
Yes.
So that is why in no scenario today in your discussion as well as in your clinical practice, because MRC is now universally easily available. In no scenario today, ERCP or PTC or any invasive investigation for that matter should be done only for diagnosis, because there are non-invasive options available if you are going to have only a diagnostic investigation. Okay, let's see the MR. थोड़ा distort हो गया image. Anyway, carry on.
So actually, this case capsule was given to me, sir.
Okay. किसने बनाया है? Distort क्यों किया image को? See, when you are trying to adjust, this is for everyone. When you put an image in a PowerPoint and you are trying to reduce the size or anything, you have to move the corner. If you move it from middle, then the image will get distorted. If you want to reduce the size, you have to put your cursor at the corner and then take it up or down. This image has got distorted. Chalo, carry on. This is very frequent. Even some very senior people I have seen, when they are presenting, they present distorted images. So you have to know how to crop or how to reduce the size of an image.
Yes. So there is fusiform dilatation of the extrahepatic biliary duct with tapering along lower margin of the CBD. Means
Where
lower end of.
Where do you see the lower CBD?
Your cursor is not on CBD.
So this is duodenum. No, this is duodenum, sir. But actually, I am not able to see the lower.
So say that. Okay. Say that there. See, don't imagine things. Say that the extrahepatic bile duct is hugely dilated. This is a huge dilatation, massive dilatation, yes, in a fusiform manner. I do not see the lower normal CBD.
Yes.
Bas.
Okay. And sir, there is even right and left hepatic duct are also dilated, but it is not in proportion with the extrahepatic, means common bile duct dilatation.
Even the common hepatic duct, I think,
yes, sir,
is dilated. So,
yes,
but again, that is disproportionate.
Yes.
What else?
Sir, pancreatic duct, I am not able
In the
to
biliary
see.
tree, anything else? So you said right and left ducts are dilated. What about further branches? What about right anterior sectoral, posterior sectoral?
So these are also dilated, right anterior and right posterior, but they are also not means in proportion with the
First
common.
and second order ducts are dilated. What about the third order and peripheral ducts? They are not dilated.
These are not dilated, yes.
There is no intrahepatic biliary radical. When we say intrahepatic biliary radical, we are meaning peripheral ducts.
Yes,
so the ultrasound finding is correct that the peripheral ducts are not dilated. It is only the first and second order ducts which are dilated, but that dilatation also is disproportionate because the extrahepatic bile duct has a fusiform dilatation.
Yes, sir.
Okay. What about, do you see, I don't know whether I can use my cursor, but this, see this in the right posterior ducts?
So here.
No, I think you are not able to see this one. So I don't know whether,
sorry,
Rajan, would you say that these are probably small cholangiolytic abscesses?
Difficult to say, sir. It needs to be cut off from the duct. They have to see it on the monitor. You cannot see a film and comment whether it's a cholangiolytic abscess or not.
Okay.
It needs to be dynamically assessed whether it's a continuation of a duct or a cholangiolytic abscess. Also, I wanted to mention that this looks like a saccular dilatation of the CBD rather than a fusiform dilatation. So
the horizontal diameter is more than the vertical.
Yeah, I doubt it's because of the are quite enlarged.
So, you were saying something about the pancreatic duct.
Yes, sir.
Say again.
Sir, actually, I am not able to see, sir.
I think it's not seen in the image, but when we saw the films, probably the pancreatic duct is coming somewhere here, but we also could not appreciate where the pancreatic duct and the normal lower end of the common bile duct are joining. So we could not comment. So what are you trying to see at the lower end?
Sir, that common channel, sir, whether it is long or short. Anomalous pancreatico-biliary junction.
Also, the important thing that of course
and
is important.
That dilatation is not extending up to pancreatic duct part.
Yes. The other way, that whether the pancreatic duct is joining the cystic dilatation or whether it is joining the normal common bile duct. Because if you can see that the pancreatic duct is joining the cystic dilatation, then obviously you will not make an attempt to completely excise the cyst, because in that process you will cause damage to the pancreatic duct.
Yes.
So it is very important to see the junction of the pancreatic duct, whether it is with the cyst or whether it is with the normal lower CBD. That is one. Second, you have to see the proximal extent of the cyst so that you can ensure complete excision of the cyst, where the common hepatic duct is to be divided. Third, what my colleague in SGPGI, Dr. Richa Lal, has pointed out and published also, that in these patients, in patients with choledocal cyst, anomalies of the right ductal system are more common. So more often than usual, you will see an right segmental, subsegmental, sectoral, or even right main hepatic duct, which is coming and joining either the common hepatic duct or even the cyst. So you have to try to identify that, because if you do not identify it and you go for complete excision of the cyst, you may cause injury to one of these ducts, which if you recognize during surgery, you will have to repair it. If you don't recognize, it will be the cause of bile leak in the post-operative period, which you would think is an anastomotic leak, but it is not an anastomotic leak. It is a aberrant duct. These are two important things at the upper and lower end, which you have to see in a cholangiogram.
Okay.
Next.
So these are the axial images. These are axial images, T2 and liver is a normal side shape And so there also intrahepatic, we can see this intrahepatic biliary means first order and second order radicals are dilated without peripheral duct dilatation. And this is the left duct, this is right anterior, this is right posterior, and they are joining here, sir. And from this it is looking, sir, common hepatic duct part is dilated, but and from this point, sir, this dilatation, disproportionate dilatation is starting, sir. And this is the gallbladder. Cystic duct is joining into the cystic dilatation.
And in a 33-year-old, you have to mention there is no filling defect inside the common bile duct or the peripheral ducts.
Yes.
Because adult more likely present with malignancy.
Right duct, probably there are some signal voids.
So this one.
Yeah, in the second row, first column and second column, you see some signal voids.
Yes, sir. This black. Yes, sir.
Also, you have to comment on the spleen, because on ultrasound they said splenomegaly, and if you have splenomegaly, you should comment on ascites. You should also look at the portal vein whether there is any evidence of thrombus in the portal vein.
Okay.
Okay, then.
So this was the report.
Anything which we have missed on MR, or report also says the same thing?
Sir, common confluence of right anterior and posterior duct with hepatic duct trifurcation pattern.
Is that of importance to us?
No, sir, because we will not go up to that point, sir.
So intrahepatic biliary anatomy is important when you are doing liver resection.
Yes.
Extrahepatic biliary tree is important when you are doing cholecystectomy or choledocal cyst excision or pancreatic oophorectomy.
Yes.
More or less the same, nothing.
Yes.
Now what will you do?
Sir, I will offer him surgery, sir, and after getting all the clearance, I will offer him this choledocal cyst excision with Roux and Y hepatico-jejunostomy.
What about the spleen?
Sir?
Spleen, there is splenomegaly. Here also they say spleen is mildly enlarged in size. Are you worried?
Sir, then, sir, I will do, sir, first before surgery, sir, CECT abdomen, sir, to see portal hypertension and liver.
MR does not show portal hypertension. What do you want to see in CT for portal hypertension? What on CT will tell you there is portal hypertension?
Vascular anatomy, sir, clearly, sir.
Can you not see the vascular anatomy on MR?
So if we are doing MR angiography, then we can see, sir. MRI with MR.
Should we not have done that, because on ultrasound there was hepatosplenomegaly, isn't it?
Yes.
They did mention hepatosplenomegaly. So if we had a suspicion of portal hypertension, then we should have done a one-step or one-stop investigation rather than having two investigations. So MR, that is why in many centers now, even say for hilar cholangiocarcinoma, where you want to see the biliary anatomy, you want to see the vascular anatomy, both artery and portal vein, many centers will do a one investigation, that is MRI with Mrcp and MR angiography. That gives you all the information. Yes. Rather than doing two investigations. So same way, in a patient with biliary disease, if you are suspecting portal hypertension, you should probably ask for MRI with MRC and MRA.
Okay?
Yeah.
Yes.
Okay. So for the moment, for the sake of discussion, let us presume that there is no portal hypertension.
Okay.
So you said you will advise surgery.
Yes, sir.
What surgery do you have in mind?
Sir, choledocal cyst excision with Roux and Y hepaticojejunostomy, sir. And at the level of, sir, means proximal extent will be means at the common hepatic duct.
So any special preparation required in this patient? He is jaundiced, so
yes, sir.
Want to do something?
Sir, pre-operative biliary drainage, sir, it is not required, sir. No, sir.
So when would a pre-operative biliary drainage be required in a patient with choledocal cyst?
Sir, if he is having symptoms of cholangitis, sir.
Suppose he has a fever of 99.8, counts are high, you will go straight away for biliary drainage?
No, sir. First, I will start medical with antibiotics. If it
the correct statement is indication for biliary drainage in a patient with choledocal cyst or biliary stricture, or for that matter even CBD stone, is uncontrollable cholangitis. Treatment of cholangitis is not biliary drainage. Treatment of cholangitis is a step up fashion. You give, in some patients you can treat even the patient with oral antibiotics as an outpatient. If
yes,
the patient is having high grade fever, counts are very high, you may like to admit and give parenteral antibiotics. If the patient doesn't respond to parenteral antibiotics in about 24 to 48 hours time, or if the patient presents with severe systemic sepsis, that may be an indication of direct biliary drainage. Otherwise, this is a common mistake which most of you do in the exam. As soon as you say cholangitis, you go for biliary drainage. That is not correct. It is uncontrollable or severe cholangitis which is causing systemic sepsis. Okay?
Yes.
Ajay, we are discussing a young man with choledocal cyst. Okay, so so what preparation? When this is asked, don't say I will not do biliary drainage. First, tell what you will do. Start with a positive statement first.
So I will start means give antibiotics, sir, vitamin K also.
You said his PT-INR is normal?
Sir.
So if PT-INR is normal, then why vitamin K?
Do you give vitamin K to all?
So there's no any special preparation, sir, I will give.
What about hydration? What about
Adapted Pandey, sir, Suresh.
Suresh Patel. Suresh Patel.
Oh, sir.
Question is, do you give vitamin K to all patients with choledocal cyst?
No, no, sir. No.
Second question is, do you give vitamin K to all patients with jaundice?
No, sir. No, sir.
Suppose you have obstructive jaundice like this patient, but PT-INR is normal. Would you give vitamin K or no? I think most centers would give. If a patient has obstructive jaundice, even if PT-INR is normal, you presume that there may be some vitamin K deficiency, there may be some underlying coagulopathy, although PT-INR is normal. So I think most centers in practice probably would give vitamin K. Dr. Desai said hydration.
Yes, sir. Hydration. I will start.
These are standard things which you
yes,
do.
Sir. Hydration.
You are going to operate on a patient with jaundice. You hydrate the patient. A lot of groups now believe in glucose loading unless the patient is diabetic. So dextrose drip. Vitamin K if the patient has jaundice. Even if PT-INR is abnormal, you will give vitamin K and recheck. Here there is no need to recheck. You just give vitamin K. But if PT-INR is abnormal, then you give vitamin K, you recheck. If it doesn't become normal still, then
sir, we can give, sir, fresh fluorescent plasma, sir.
Yes, so all these things you need to mention. Okay, not in this case, but as a general. What about diuresis?
Lot of he
is already.
Would you use mannitol?
Mannitol, yeah. Lot of books probably still would mention, or at least the older editions mentioned. So it used to be a practice, but
if not, why not?
Sir, it will more cause dehydration, sir. Means depletion in the intra means vascular volume, sir.
The answer is it causes electrolyte disturbances.
Yes.
And osmotic diuresis also results in renal tubular cell vacuolation. So it impairs the kidney rather than improves the function.
Okay. And it all used to be recommended as a part of preparation of patients with jaundice who are going to be operated. But I think almost all centers have stopped doing it. And the physiological reason is what Dr. Desai has told. Any other reason for not using mannitol?
Right now, they are using only for hepatocellular jaundice. Synthetic alteration में ACLF में इनमें कभी-कभार use करते हैं, otherwise not.
Sorry, say again.
ACLF और synthetic dysfunctioning में जो hepatocellular jaundice है उसी में use कर रहे हैं.
Dr. Vinay says that if you have a situation like ACLF, where there is hepatocellular damage, then probably some groups are using.
In the terms of cerebral edema develop होगा.
Decrease ICP, sir.
Yes, to decrease the, yeah, that is a different, that is not for
hydration, Ankur. What is the role of, why do you hydrate this patient? That will give you most of the answers. Why
hydration is specifically mentioned?
Why do you want to give IV fluid? You told IV fluid, no?
Yes.
Why? Which is more likely to have a severe sepsis?
So, obstructive jaundice patient means they can go for sepsis and to.
Yes, you are correct partly. Which is more likely to have a severe sepsis? A patient with a biliary obstruction with thick bile or a thin bile?
So, thick bile.
So, what do you want at this point in time? A thin bile.
Yes, sir.
Thin bile, most important things are only two. That is, one is hydration, and second thing is liver producing the sufficient amount of bile. And after these two comes the role of stenting, that you will require stenting or not. So therefore, any patient who comes with choledocal, the basic recommendation is IV antibiotics, hydration, and correction of coagulation.
Okay.
Okay. So we have about 10 minutes. Describe the procedure in 10 steps.
Sir, first means incision. I will give right subcostal incision, and then, sir, I will see the hepaticoduodenal ligament and liver, and then. Sir, I will loop the common hepatic duct, means just proximal to cystic dilatation, sir. And I will use the gallbladder for retraction. And then I will divide at the level of common hepatic duct, sir, just proximal to cystic dilatation, sir. Then I will mobilize the I will just mobilize the distal part of this dilated choledocal cyst, and I will go up to the I will try to go up to the waist of the cyst towards pancreas, sir. And once I reach there, then I will apply either we can apply hemoclip if we are able to reach the narrowest point, sir. That dilated part is it is getting narrowed, sir. At that level, we can apply this hemoclip, sir. Then, sir, I will make the rule limb of about 40 to 50 centimeter, and I will do wide hepaticojejunostomy, sir, using PDS 4, sir.
How do you ensure that you don't cause a damage to the pancreatic duct?
Sir, while means mobilizing the distal part of the choledocal cyst, means I have to be means first this intrapancreatic dissection, sir. There I have to be means take, and sir, I should not see means pancreatic duct, sir. And if the dilated part of the choledocal cyst is getting narrowed at that point, I means I have to stop, sir. I don't have to go means more distally to that.
Yeah. If the pancreatic duct is joining the cyst, then how do you
Then,
ensure
sir, no, sir. I will means cut the duct above that level, sir. I will not go up to the deep.
How do you know where it is joining?
Sir, it will be in intrapancreatic portion only.
Intrapancreatic portion, whether the pancreatic duct is joining the cystic dilatation or that is where the importance of the preoperative imaging.
MRCP will
preoperative imaging should show where the pancreatic duct is joining. But if you have not seen that, like in this case, here we could not delineate where the pancreatic duct is joining. So how would you ensure that you don't cause an injury to the, because that happens quite frequently. Not every MRCP film shows you very clearly. So how do you ensure that you don't cause an injury to the pancreatic duct?
So, sir, then means just I will in suprapancreatic part. I means just at the level of superior surface, I will stop my dissection, sir. If I'm not sure whether the duct is joining, sir, in the where it is joining.
Leave a significant part of the cyst. If you don't dissect in the pancreas, you stop at the suprapancreatic part, then a large part of the cyst may be left behind, which is intrapancreatic.
Yes. So that if I'm not sure, then I will leave, sir.
There are several ways. One is, of course, the prerequisite is that you should have a good MRCP to delineate the pancreatic duct relationship with the cyst or the normal bile duct. As I said earlier, if it is joining the normal narrow lower end of the bile duct, then you can go for complete excision of the cyst. If it is joining the cyst, then obviously you cannot excise the cyst completely. You have to perforce leave a part of the cyst, the intrapancreatic part. But if you have not seen the junction, then you have options. You can do an intraoperative cholangiogram, which may or may not show the junction. Or what most surgeons today would do, they would, before going deep into the pancreas dissection, they would open the cyst somewhere in the suprapancreatic part and keep seeing from inside. So sometimes you can see pancreatic juice coming. So then you try to see whether it is coming from the lower opening or whether it is coming from the lateral wall of the cyst.
Okay.
And if you cannot be sure where the pancreatic duct is joining, then perforce you may have to leave a part of the cyst wall, especially on the left side, where you expect the pancreatic duct to be joining, because it is much better to leave a part of the cyst wall rather than causing a complete transection of the pancreatic duct. So if you do not know either from cholangiogram or from operative finding where the pancreatic duct is joining, then it is very risky to go for a complete excision right down up to the end of the cone of the choledocal cyst. And if you are leaving a significant part of the choledocal cyst behind, then what is the concern? What is the worry?
So means in maybe decades later it can convert into malignancies.
Because it is supposed to be carcinogenic.
Yes, sir.
So a lot of people would then try to destroy the mucosa with cautery. But that also you have to be careful. If you do not know where the pancreatic duct is opening, if you try to use cautery on the lateral wall, then you can cause injury to the opening of the pancreatic duct. So if at all you have to use cautery, you can use it, or you should use it only on the anterior, posterior and the right wall of the remaining cyst, not on the left wall of the cyst. Second is a theoretical discussion that there are two hypotheses. One hypothesis is that it is only the epithelium of the choledocal cyst which is carcinogenic. So then complete excision of the choledocal cyst takes care of the risk of malignancy. The other view is that the entire biliary epithelium, even the one which is not dilated, is carcinogenic. So in that case, what you are doing is you are just reducing the risk. You are not completely eliminating it, because the entire intrahepatic biliary tree remains. So this probably nobody knows that what is the which part of the biliary tract is carcinogenic or pre-carcinogenic, and how much risk reduction you do by excising the choledocal cyst. That probably nobody knows, because there is no hard evidence for this. Second important thing, as I mentioned earlier, is the frequency of aberrant ducts at the upper end. So that is why many surgeons would not do what you described, that you loop the common hepatic duct and divide it there. Because from outside, it is difficult to see any aberrant hepatic duct, especially if it is small. So again, what many people would do, they would divide the choledocal cyst somewhere in the cystic dilatation part, lower down, look from inside, because from inside you can see a duct joining on the right wall of the dome of the choledocal cyst. If there is an aberrant duct, it will be joining there. So then you divide or you excise the choledocal cyst, taking precaution to preserve or protect that duct. Other option is that you identify the duct, you divide it, but then you have to include it in the anastomosis. So there will be two anastomoses, or if they are close together, you may have to do a septoplasty. So there are 2 or 3 important points which, when you describe the operation for choledocal cyst, one is that the plane between the choledocal cyst and other structures, especially the portal vein in the hepatoduodenal ligament, more so if the patient has had recurrent cholangitis, that plane may be very, very difficult. So there will be dense inflammation, fibrosis, adhesions. And in some cases, you may not even be able to do that. So that point, you have to say that I will carefully dissect that plane. Second is the intrapancreatic part, and third is the upper part. So suppose you are not finding a plane between the choledocal cyst and portal vein.
So then means I will leave the posterior wall of the choledocal cyst behind, sir. That Lily's method, sir. This is called Lily.
You still do an end to side, and in choledocal cyst or in cholangiocarcinoma, it is always end to side. In biliary stricture, it is a side to side. But here, because it is an excision, but then you leave the wall of the choledocal cyst, which is adherent to portal vein, and again, then you try to destroy the mucosa. But then when you are taking the bites for the end to side anastomosis, the posterior sutures will obviously take a part of the remaining choledocal cyst wall. Okay.
Some of the things, Ankur, I think what you mentioned. One thing is you were telling something that you will during the surgery you will look at the liver. You told first thing you statement you gave.
So just sir, for means just overview, sir. Liver, gallbladder, everything, sir.
But what would you? Okay. So just to have a feel that the liver is not cirrhotic.
Sir, I'm not able to hear.
Liver is not having malignancy. What?
Sir,
what are you looking for?
Not
what are you looking for in the liver?
Sir, that means we were suspecting some cholangial abscess in the MRCP that we can find, sir.
How will
and
you in your procedure?
What finding will make a difference in your operative plan or procedure? Cholangolytic abscess, if it is there, how does it matter?
Think over it. Second thing, I think we are running short of time. Second thing, you did not mention that you will do the cholecystectomy part first. You will mobilize the gallbladder. I think that is an important part of choledocal cyst. That cholecystectomy, you will mobilize the gallbladder in an anti-grade fashion, and then subsequently it is possible to loop the choledocal cyst. Third thing, I think, which is very important, is that you will always like to have a palpation on the posterior wall of the choledocal cyst, that you don't have a replaced right hepatic artery. That is a very common mistake while doing a choledocal cyst excision. Other than having a dense adhesion with the portal vein, that you may have a replaced right hepatic artery. Fourth thing we did not mention is that a right hepatic artery, which is a normal course, has always to be seen near the hilum, because it goes posterior to the choledocal cyst at the hilum. So that has to be preserved, that will sometimes cause injury. Fifth thing which is important, I felt, is when you are doing a dissection into the intrapancreatic portion to identify the choledocal, the pancreatic duct, there are two most important things. One is a nipple-shaped opening, which is to be seen. Any area which is showing a nipple onto the medial wall, onto the left wall, that has to be taken care of. Second thing is, if you are able to see a pancreatic juice, it is good. Otherwise, just put a pressure onto the pancreas, that may show some fluid coming out from some side. That is a suspicious area. Next thing about malignancies. What are the malignancies associated with choledocal cyst?
So cholangiocarcinoma, gallbladder cancer, hepatocellular carcinoma, pancreatic head malignancies. Most common is cholangio, sir, followed by gallbladder cancer.
And other than this is ampullary carcinoma and duodenal carcinoma also. Let me tell you, this is not, if you see the list, that includes duodenal malignancies also.
Yes.
So, it is not only the biliary malignancies that is important. So, there is something, initially it was thought that abnormal pancreatico-biliary junction leads to pancreatic juice going into the CBD. That may be a pre-malignant condition. But then subsequently, there are a lot of work which is going on the mutations which say that there are people who have Choledocal cyst have certain mutations which may lead to progression of malignancy. So still not clear what is the cause, but there are so many malignancies which may be associated. So a distal remnant, it is only I think 10% of the Choledocal cyst that you are leaving. One part. Second thing, if the Choledocal cyst is extending proximally into the intrahepatic portion, you are leaving that. That is second part. They can all lead to malignancy subsequently. We don't know what the cause is. So you have to take care of these 5-6 points which you need to mention in the surgery. Second thing, you mentioned subcostal incision. I think traditionally it was subcostal incision, but entire world, one is laparoscopic and otherwise people are going towards midline incision now. Because that is the safest incision as compared to subcostal. What incision do you use, Ankur, always?
So actually, I think I have seen only one open, sir. Means all the 100 means their sir has done laparoscopic, sir.
So then why did you start with open? Actually, in the beginning only you should have said that it could be done open or laparoscopically. If I am doing open, I will use this incision. If it is laparoscopic, then it is fine. The rest of the procedure, of course, is same. Okay. Any student wants to ask anything?
Sir, only one thing, sir. Sir, that you have already told, sir, means after the history, means during differential, means in this type of patient, should we tell means hepatico-duodenal ligament, tuberculosis, and very less likely malignancy? No, sir.
No.
Okay, sir.
Don't make a diagnosis in clinical exam of a condition of which you may not have seen more than 2 or 3 cases in your 3 years.
Okay, sir.
All these are histological or imaging diagnosis. They are not clinical diagnosis.
Even Choledocal cyst diagnosis is the diagnosis of.
Sir, so in this type of we have to make only polylithiasis with polydopolithiasis. That's it. Only single diagnosis.
Choledocal cyst you can mention in a young patient, but as Dr. Vinay also is saying, choledocal cyst also is not the first diagnosis unless, as I said, it is the child with a palpable lump and jaundice,
yes,
child or an adolescent. That is the only situation where you can make a clinical diagnosis of choledocal cyst. Otherwise, it will be basically the commonest cause of jaundice, surgical jaundice, and commonest cause of obstructive jaundice is still CBD stone at irrespective of the age.
Yes. Okay.
But definitely no clinical diagnosis of tuberculosis or any other this IgG4 cholangitis and all those things. They are possibilities. Final diagnosis may turn out to be that. So as I said, in this case, if you make a clinical diagnosis of choledocal cyst, at least I will not give you passing marks in this case, because that cannot be the clinical diagnosis. Okay, can we close if there are no other questions?
Thank you, sir.
Thank you, sir.
Thank you, Rajen. Thank you.
Thank you, sir.